Xin mời các anh chị đặt các câu hỏi cho các báo cáo viên. Bài hôm nay có hay quá mà.
So, good morning. Dr. Thảo from University Medical Center. I have one question for you about ERAS pain management. I didn't see you mention about fascia plan block for colon surgery, like ESB or TAP block, or even the IV lidocaine. How about your opinion about this fascia plan block for pain control?
Oh, sorry, is the question for me or is it for
Thank you for asking that wonderful question. We do use a lidocaine IV for chronic pain patients, but we not generally used as much. As far as tap blocks, there are, again, under specific hands, could be very beneficial. Some researchers have shown that tap blocks work 25% of the time in 50% of the times in 50% of the people. So basically means about 25% of the time. So my personal definition of a tap block is tap, 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 where's my pain medication? However, under appropriate circumstances, it could be utilized effectively.
Dạ, xin mời các anh chị.
Dạ, kính thưa cô và quý thầy cô, em xin có một câu hỏi cho bác sĩ Sydney Phạm ạ. Dạ. Hi, I'm Dr. Phương, and I'm very impressed by your report and would like to have some calling questions. Actually, two questions with a nearly same content. So, first of all, intraoperative period. Compared to conventional laparoscopic urological surgery, what are the most common intraoperative complications specific to robotic surgery, and how can they be effectively prevented? And the second question is this nearly same content in post-operative period, the specific post-operative complications, so we should pay attention to. Thank you.
Thank you for those questions. For me, for these urologic procedures, mainly at my hospital, I think the majority of the urologists as well as the gynecologists, probably about 90% or more, have switched to doing everything robotically versus laparoscopic. I think the advantage that they have told me, the surgeons themselves in the pelvis, is that they're able to reach these really difficult locations a lot easier. And the tools that they use with the robotic, they're able to reach those locations a lot better, have a lot more movement, able to do better margins for surgical purposes and for cancer purposes. Versus with the laparoscopic, a lot of times they say maneuvering with the equipment gets a bit hard to reach certain paces just because the limbs of the laparoscopic can get kind of tangled with each other. I would say the biggest difficulties that I've run into when doing these robotic procedures is because there's often more port sites that they have to place their cameras. Oftentimes there's usually 5 or 6 versus laparoscopic, which has less from my experience. There is more risk of them injuring a major vessel. I actually assisted in a case where when they placed one of the trocar to use their instruments, they actually hit the aorta. And so we had to emergently open, which is quite difficult in a robotic case where their position and their arms are tight at their side. We had to push all the equipment out of the room. We had to quickly reposition the patient, get their arms out, get them get all the equipment in. And so really the most difficult thing is getting all the equipment out, and the bulkiness of being able to open is more difficult with robotic versus a laparoscopic procedure. Advantages that issues that I've seen with robotic procedure versus laparoscopic. Overall, I think they're very similar in terms of recovery when I do see them in the recovery area. A lot of them will complain about shoulder, kind of referred pain in the shoulder and neck due to all of the insufflation as well as the port sites that are there. Another thing is with robotic procedures, they're in that very steep Trendelenburg position a lot of times, and so a lot of patients will wake up more edematous with a little bit more puffy vision than with the laparoscopic procedure. So that's the difference in kind of the difficulties that I see with these robotic procedures.
Thank you.
Xin mời các anh chị còn câu hỏi nào tiếp tục không? Chúng ta còn 3 phút nữa để tới cái next section. Mời bác sĩ Trúc. Dạ.
Dạ, kính thưa chủ tọa đàn. Em xin có một câu hỏi cho bác sĩ Bona. Hello, I'm Trúc from Bình Dương Hospital, and I have a question for Dr. Bona. What considerations should be taken when monitoring post-operative patients who underwent restrictive fluid management during surgery?
The most important thing you have to remember is you have to treat your patients. So we do restrict fluid management. However, that does not mean you don't give the fluids when they're required. We try to address urine output and hemodynamic stability. So if the patient does need a little bit more fluid based on how they have been, they've presented themselves to you, please use your judgment, and especially after the case surgery, give them the fluid. On the case yesterday, when we did the case, even though we went in the thorax, the patient had a little over a liter of urine output, okay, but we ended up giving about 4 liters of fluids, even though it was a case that it was a thoracic case, and we would not have necessarily given that much. However, in that patient, the blood pressure variations were so significant that we needed to do that rather than just pressors.
Chúng ta có còn câu hỏi nào nữa không các anh chị? Vậy thì chắc tới giờ ha. Thì chắc là mình ngừng ở đây, nhưng mà mời các anh chị ở lại có gì chụp hình với mấy ông chủ tọa đàn cho vui.